Good afternoon, everybody. Welcome to today's event. And right at the beginning, I'd like to apologize for the internet issues, which has led to a delay in starting today's program. Usually we are dot at 2 o'clock. So welcome to today's event. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. Today's theme is anemia, which is a silent killer and a major issue as far as obstetrics and concerned. But as usual, before we start with the scientific proceedings, I'd like to express my gratitude to the AMOG's office bearers, our President, Dr. Rajendra Singh Pardeshi. Next slide, please. Thank you, sir, for your blessings and your guidance and for all your support for our academic endeavors. Thanks also to our Secretary of AMOG's, Dr. Sujata Darvish, is an office bearer of the Mumbai Society, Joint Associate Editor of Jogi, and of course, the Secretary of AMOG. Next slide, please. I'd also like to express my gratitude to Dr. Lakshmi Shrikhande, Chairperson of ICOG, and Dr. Ashok Kumar. Next slide, please. Secretary of ICOG. Thank you for the ICOG credit points, not only for this event, but also for all the events which we've done in the past. We have two eminent chairpersons today, Dr. Sudesh Doshi, who's the Zonal Coordinator of AMOG's. Next slide, please. And sir is somebody who we look up to. He's somebody who has done a lot of pioneering work in his part of Maharashtra. And thank you, sir, for joining us today. I'd also like to welcome Dr. Sarita Bhalera, who is a Governing Council member of ICOG, immediate past president of the Mumbai Society, Chair West Zone AICC RCOG, and she's contesting for the post of Secretary of ICOG very soon. Wish you all the very best in your endeavors and hope that you will get elected unopposed. We have two fantastic speakers today, Dr. Rekha Rajesh. Next slide, please. She's the president of the Hosuru Beauty Wine Society. I visited that little society a long time ago. It seems long time because we've lost about 2 or 3 years because of the pandemic, and it seems like a very long time ago, but I'm pretty sure it was in the recent past. He's going to be speaking to us about Anaemia Mukt Bharat and oral iron. And next slide, please. I'd also like to welcome Dr. Basav Mukherjee. Sir is the immediate past Vice President of FOXI, very much at the helm of affairs during AICOG 2023 in Kolkata. We saw what a fantastic show the entire Bengal Society put in. And the silent worker of the society, of course, as is well known, is Dr. Basav Mukherjee. I'd like to welcome on this occasion the chief guest for today, Dr. Mandakini Meg. Ganesh, can we have the appropriate slide displayed, please, for Dr. Mandakini Meg's introduction? Madam is the past chairperson of ICOG. She is the longest serving member of the Mumbai OBGYN Society. Is somebody who's made ICOG a name to reckon with in academic circles. During her tenure, she has promoted and encouraged so many grassroots workers. She's somebody who's worked with the government, not only of Maharashtra, but also of India. She was Deputy Director of Health Services of Government of Maharashtra, in charge of family welfare, PCPNDT, MTP. And in that capacity, she has helped to save so many doctors who were unfortunately victimized because of the PCPNDT law in the past. Welcome, Mandakini Meg, madam, and I will hand over the stage to madam to give us a few words of blessings.
So, good afternoon, everyone. Very nice to see everyone here. And it's a great pleasure, Pratik, for your CMEs and, the very apt subject which you keep. And you can see the chairperson, everybody in the present here, that itself shows the seriousness and commitment of their time for this very important cause. Also, the wonderful speaker you have already introduced. So today's topic is Anaemia Mukt Bharat, that we know. And our beloved president of FOXI is having the mission of, we have done so many CMEs and Anaemia Mukt Bharat all over India. And I think this is a favorite topic of the policymakers of the health, because in spite of so many efforts, continuous efforts, I was a part of the RCH part 1 when we made the this PIP. PIP is a project implementation plan where we, keep some kind of budget and policies for the, prevention of anemia, and so many other things are there, which I don't want to mention here. Family welfare, contraception, postpartum, IUCD, everything. But anemia was the main component of the policy making. And also all of you know that Government of India distributes the RCH packages, right from the rural to the municipal corporation, even to Mumbai. Those packages are there, which contain 100 tablets of the ferrous sulfate, and also the deworming. It's a regular program of Government of India deworming. And I think they have succeeded a lot. And in that order where we have to prevent the anemia in order to bring down the maternal mortality. And I think we are in the state, we are very proud of Maharashtra and other parts of India, where we have brought the maternal mortality due to anemia, PPH, to 33 per 1 lakh. And I think 2030 target is already achieved. The SDG target is already achieved because of the awareness and keen interest of all the practitioners and the professional bodies like POXI, AMOX, AMWI, everyone there. I think your dedicated and sincere efforts to help the government in bringing down the maternal mortality is commendable. And I think we appreciate. I was yesterday talking to some bureaucrat there. They say not only government, every time if the government fails or they don't have facility, everything falls on the shoulder of private practice. And we are always there to shoulder the responsibility, whether it's a cytology camp, whether it's a hemoglobin camps, and all over we can see. So I think with these words, I really wish Pratik very best to this webinar. And thank you making me the part of this, because I keep on telling Pratik and that whenever you have a very important subject of policy, please invite me and I'm always there. And Sarita and myself, we MWI people, we duty and devotion is our motto. And with this motto, I think in Basab, wonderful AISUG, once again, I must thank you on this platform. And all of you, we being together is a great pleasure and also a great fellowship for all of us to take our health of the women forward. Thank you very much.
Thank you, Dr. Mandakini Madam, for gracing the occasion. To her long list of credentials, I must also add that she is my zonal coordinator of AMOX. For all my academic programs with the AMOX Endocrinology Committee, her blessings are always there with me. Thank you, ma'am, for being here. And thank you for speaking on this occasion.
And also,
without further ado, I would request the first chairperson.
Mention about my other part also, which you mentioned for Sarita.
Can I request Dr. Sarita Valera, ma'am, to please introduce our first speaker, Dr. Rekha Raj. Ganesh, can we have the CV slide displayed, please?
Thank you very much. And I'd like to thank Dr. Pratik Tambe for inviting me to participate in this wonderful program. And I think that you have really taken a very, very important topic, which is, I'm sure, of great interest to all our viewers. It gives me great pleasure to introduce to you Dr. Rekha Rajesh. Dr. Rekha Rajesh is currently the president of the Obstetric and Gynecological Societies of Krishnagiri, and she is the clinical director of the Vijay Shrishti Fertility Center at Hosur. She has keen academic interest. She's done her diploma in reproductive medicine from Germany. She's also done a diploma from London. She practices fertility as well as high-risk pregnancy, and she's trained in UK and as well as Germany. She's also the joint secretary of the IMA of Hosur, and she's a life member of many prestigious organizations like ESAR, ASRM, IMS, PCOS India, and the IAGE. Over to Dr. Rekha Rajesh.
Thank you, madam. Thank you, Pratik sir, for giving me this opportunity. And thank you, Basab sir and Mandakini madam, for joining me here in this webinar. I'll just share my screen. Just like Mandakini madam has introduced anemia as a topic, anemia is a condition which all of us do confront in our daily practice, and it's rampant across all ages. And it's a medical condition in which hemoglobin levels below a certain number and RBC count below the normal range. There is a lack of healthy RBCs to carry adequate oxygen to the body tissues. So to tell you, the normal levels for women are between 12 to 16, and for men is between 13.5 to 17.5 gram per deciliter. Mild anemia is defined as 10 to 12 in women and 10 to 13.5 in men, and moderate is between 8 to 10, and severe anemia is below 8. Generally, we classify anemia maybe on the basis of the cause or on the morphology. On the cause, when it is acute blood loss, there's inadequate production or excessive destruction. On the basis of morphology, if it is normocytic, microcytic, or macrocytic. Based on this normocytic, microcytic, or macrocytic, it is based on the mean corpuscular volume, which is less than 80 FL. And in normocytic is it between 80 to 100, and macrocytic MCV is more than 100. Iron deficiency anemia is divided based on the lab test when the serum iron is low and ferritin is low and TIBC is elevated. When we have to diagnose thalassemia, if the serum iron is normal or elevated, the serum ferritin may be normal or elevated. TIBC is usually normal, and hemoglobin electrophoresis is normal in the alpha thalassemia and abnormal in the beta thalassemias. But in the anemia of chronic diseases, serum iron is normal or decreased. Serum ferritin may be normal or elevated. TIBC may be normal or decreased, and hemoglobin electrophoresis is usually normal. Mostly the normocytic pictures are seen in acute blood loss, chronic diseases, hemolysis, infection, inflammation, malignancy, renal insufficiency, and sickle cell disease. Macrocytics are again based on certain tests where we evaluate B12 and homocysteine levels and the serum folic acid levels. If it is elevated, it is vitamin B12 level deficiency. If the MMA levels are normal, it is folic acid deficiency. The serum B12 levels and folic acid, when it is normal, the etiology is of other causes, mostly due to alcoholism, liver diseases, bone marrow disorders, hypothyroidism, or any other medications like chemotherapy or antivirals. They usually present with symptoms of fatigue, headache, yellow skin, irregular heartbeats, chest pain, cold hands, dizziness, leg cramps, and insomnia. But they also have other symptoms, like when you see their hands and knuckles, the changes in the skin in the knuckles, the nails changes. So we need to actually examine the patient and identify on a clinical scenario. On a global scenario, India has the highest prevalence of anemia in the world, which is close to around 40%. And again, because of the different, different causes, and it is again divided between absolute and functional iron deficiency anemia. Usually, the absolute anemia is defined when there is increased demand, decreased iron take, and decreased absorption or chronic blood loss. It is called absolute iron deficiency anemia, where the plasma iron is low and iron stores are also low. In cases where we see where there is inflammation or erythropoietin therapy, that we usually see it in the functional iron deficiency anemia. Children aged below 5 years depend on their mother for the iron needs and hence are usually neglected. The anemia continues to rise among children and women in the reproductive age group. This is based on a survey in the year 2020. And anemia cases in India is also on the rise. This is the NFHS survey in 5. This is a recent National Family Health Survey. And 67.5% of the Indian children aged between 6 to 59 months were found to be anemic. So iron deficiency anemia and pregnancy is also responsible to percolate this condition in the children. Why is there such a prevalence in India? It is mainly due to poor eating habits, inadequate dietary intake of iron and defective iron absorption, early onset of childbearing, higher parity, and shorter intervals with the pregnancy. Excessive physiological blood loss during menstruation in the adolescent and the reproductive women and pregnancy, hookworm infestation, and lack of access to good health care. Now, Anemia Mukt Bharat was started, and since 2018, it has been taken up very seriously, and all of us have been participating in bringing about a change in these women. But anemia across all age groups is very high still in India. 58% of the children between 6 months to 59 months, and in adolescents, it's around 54%, both in boys and girls. In boys, it's around 29%. In women in their reproductive age is 53%, and 50% of the pregnant women are found to be anemic, and 58% of the breastfeeding mothers are found to be anemic. So it is very important that we intervene and correct. And there are many states which have achieved, like Madam has told, there are states like Maharashtra, Kerala, which have achieved the targets. But what is it that they have done differently? They have set higher targets and interdepartmental convergence and regular programs to review at the highest level. There is no supply stockouts or ruptures in the supply chain management. The BCC and IEC counseling mass and mid-media levels are very high. Monitoring and strengthening outreach services are covered very well. There is a very high political commitment, special strategies for malaria endemic zones, screening, tag tracking, high-risk anemia cases and treating them, focusing on promoting iron-rich diet and combination of different interventions, fortified diets, iron folic acid proper supplementation, deworming, etc. has been implemented to the next level. The burden is also because of low iron stores during pregnancy in anemic mothers and poor iron stores from infancy, childhood deficiencies and adolescent anemia. Inappropriate diet, excessive consumption of iron inhibitors like tea, coffee, and calcium-rich foods, and low intake of iron enhancers like vitamin C. Low bioavailability of the dietary iron, and 50% of the population is consuming less than 50%. Iron loss due to parasitic load, poor environmental sanitation, unsafe drinking water, and inadequate personal hygiene. Maternal anemia could be because of increased iron due to tissue blood formation and energy requirement during pregnancy. Iron loss from postpartum hemorrhage, teenage pregnancies, and repeated pregnancies with less intervals. There is a huge public impact of this anemia, which reduces the physical development, impact on pregnancy outcomes, reduced cognitive development, and economic impact, which is why we should address anemia for both short-term, long-term, and integrational benefits. Improvements enhance human capital, contribute to the virtuous cycle by fostering economic development, and in due course enhances health and nutrition of women and children. The World Health Assembly has proposed a target of 50% reduction in anemia among women by 2025, and NHP 2017 commits to reduce anemia prevalence by 3% per year. The annual average rate of reduction of anemia prevalence currently is close to around 1%, and we are committed to achieve a target of 3%. So, Anemia Mukt Bharat is based on these 3 pillars, and it is using a strategy which is 6 by 6 by 6 to combat anemia. That is, they have 6 beneficiaries, they use 6 interventions and 6 international institutional mechanisms to implement this Anemia Mukt Bharat. The 6 beneficiaries include 124 million children in the age group of 6 to 59, 134 million children between the age group of 5 to 9 years, and 115 million adolescent boys and girls in the age group of 10 to 19 years, 30 million pregnant women, 27 million lactating mothers, and 17 million women of the reproductive age group of 20 to 24. The estimated beneficiaries are around 450 million, which is reaching almost nearly 50% of the country's population. The 6 interventions include prophylactic iron and folic acid supplementation, periodic deworming of the children, adolescents, and pregnant women, intensified year-round behavioral changes, communication campaigns saying solid body, smart mind, and delayed cord clamping, testing of anemia using digital methods and point-of-care treatment, mandatory provisions of iron and folic acid, fortified foods in the public health program, in the midday meal scheme, etc., and additional non-nutritional causes of anemia in endemic pockets with special focus on malaria, hemoglobinopathies, and fluorosis. The 6 institutional mechanisms are the intra-ministerial coordination, National Anemia Mukt Bharat Unit, the National Center of Excellence and Advanced Research on Anemia Control, which is at AIIMS, New Delhi, convergence with other ministries, strengthening supply chain and logistics, Anemia Mukt Bharat dashboard and digital portal, a one-stop shop for anemia. So what is new and what is it different from the previous program that they have done is there is a coordinated management efforts, intra and interministerial, target-based monitoring, and key performance indicators, reviews, and awards. They have included a lot of private schools and private organizations. Instead of 60 milligrams of they're giving 100 milligrams as the prophylactic dose, which are sugar-coated tablets. Communication materials for extensive awareness, intensive 360-degree communication campaigns, creating a Jan Andolan. Using digital methods of hemoglobin estimation and point-of-care treatment, newer treatment strategies using IV iron sucrose and FCM. The linkage with malaria, mandating use of fortified food in public health programs, specially doubled fortified salt with iron and iodine. And the linkage with academic, national, and regional networks, relearning and reworking on the policy decision. So in pregnancy, again, now we are looking at anemia and pregnancy. So during pregnancy, anemia is in the first trimester, usually 11 is the normal cutoff. Mild is 10 to 10.9, moderate is 7 to 9.9, and severe is lower than 7. In the second trimester, due to the physiological anemia, the lower level is at 10.5, and third trimester is similar, between 11 as the normal levels, 10 to 10.9 as the mild, 7 to 9.9 as the moderate, and lower the 7 as severe anemia. The different bodies define anemia at different levels, but all of it is similar. This is the ICMR definition, and this is the CDC definition. In the CDC, they add hematocrit, which is less than 33 or 32%, is called as severe anemia. Why are we worried about the outcome of iron deficiency in pregnancy? Is because it affects the maternal morbidity and mortality. It reduces the work capacity, intellectual capacity. It increases the maternal mortality, affects the immune function, and increases the risk of infections. It affects the fetus and the infant by they have low birth weight deliveries, the risk of anemia after birth, and long-term deficit in physical and mental health of the fetus or the baby. The effect on the pregnancy outcome is preterm birth, low birth weight, and possibly placental abruption and increased peripartum blood loss. The Lancet Journal confirms via an international study, which included India, that pregnant women with anemia are twice as likely to die during or shortly after pregnancy compared to those without anemia. The proper and timely management of iron deficiency anemia, especially in pregnancy, is very, very important. There are a lot of risk factors, mainly early age of marriage, teenage pregnancies, and diet, which is poor in iron-rich foods, poor in food that enhances iron absorption, and rich in food that diminishes iron absorption, dairy products, etc. GI diseases affecting absorption, short interval pregnancy, which is less than 6 months. We diagnosed based on history, examination, and investigation. So we've understood that there are, when we have done the clinical evaluation of the patient, but then there are evaluation recommendations by different bodies. And here we are allowed to do universal screening for iron deficiency anemia in pregnant women with universal supplementation. And we have to, in the CDC recommends CBC at least twice in pregnancy. And the initial evaluation should include RBC indices, serum iron levels, and ferritin levels. Empirical treatment with iron is reasonable, but we have to expect reticulocytosis within 7 to 10 days, subject to which the improvement is assessed, and following which hemoglobin and hematocrit values could be reassessed later. The diagnosis here goes based on hemoglobin estimation, the levels of ferritin, which should not be lesser than 30 micrograms per liter. Low serum iron, that less than 60 milligrams, is evident of iron deficiency anemia. Elevated total iron binding capacity, low transferrin saturation, microcytic anemia with MCV less than 80, and anemia seen on CBC. Raised erythrocyte zinc protoporphyrin, raised serum transferrin receptors, and blood indices are lower, and if required, bone marrow biopsy to for the differential diagnosis. In the management, the severity of, based on the severity of anemia, gestational age of pregnancy, and tolerance of the therapy chosen, the first line of treatment would be medical nutrition therapy, deworming, oral iron therapy, parenteral iron therapy, and blood transfusion. Medical nutrition therapy is the first line of choice. And when it is mild to moderate, it is very important to counsel our patients regarding the kind of diet they have to take and the timing of iron supplementation that they have to take. So we have to ask them to take iron-rich foods, which include jaggery, spinach, pulses, eggs, liver, fish, cereal. And mostly if they are vegetarians, they have a deficiency. And then cooking food in iron utensils, intake of heme iron, adding iron absorption enhancers like vitamin C compounds, ascorbic acid, avoiding phytates, coffee, tea intake with iron supplements, intake of iron supplements in between meals. WHO recommends routine deworming, and in Anemia Bharat, tablet albendazole 400 milligrams stat to all antenatal patients after first trimester, preferably in the second trimester, is given compulsorily. The other doses would be albendazole 400 mg stat or mebendazole 500 mg stat or 100 mg BD for 3 days. Oral iron therapy is the main role of therapy in the mild to moderate cases, and it is effective in the majority of the cases. But the absorption of iron is only 1 to 8% in the available oral iron preparations. But the absorption increases with increased dosing, that is 160 milligrams per day. Iron absorption is increased in iron deficient individuals also. So the different salts of iron are inorganic, organic, elemental, and chelated iron, and technological. In the inorganic group, we have ferrous sulfate, ferrous fumarate, ferric ammonic citrate. And in the organic ferric polymaltose, elemental is carbonic iron, chelated is ferrous bisglycinate, and technological is ferrous ascorbate. Most commonly used iron supplements are the organic ones. The general instructions are to take the tablet either on an empty stomach or at least 1 hour after the meal. In case of vomiting, nausea, and gastritis, for better absorption, to avoid coffee, tea, and milk or calcium tablets along with these supplementation. Added taking vitamin C with iron is best, as they are best absorbed in an acidic environment. And we have to start low doses to decrease the side effects. The factors affecting the oral iron absorption could be the dose, the status of the patient's iron stores, the form administered, stability in the gastric acids, elemental iron, and the bioavailability of the drug. And most important is the mind. What the mind understands, the hands do. So they need to be willing to take the supplements. So that's a very important thing that we counsel them and make them understand how important it is to take the iron supplementation for the mother and for the child. So the ferrous fumarate, ferrous sulfate, and ferrous glycinate, they are best cost effective, commonly used, and it's more, the ferrous glycinate is more effective and better tolerated than ferrous sulfate. The ferrous ascorbate is effective, better tolerated than ferrous sulfate. It has a higher bioavailability up to 40% and has rapid correction of hemoglobin. And carbonyl iron is effective, inexpensive, tolerable, and the side effects are very less. In the ferrous bisglycinate compound, amino acid chelates, they are higher bioavailability in the presence of dietary inhibitors also. The ferric ammonium citrate bioavailability of iron from ferric salts is 3 to 4 times less than that of the ferrous salt. In the ferric hydroxide polymaltose complex, it's a useful alternative formulation to those patients who cannot tolerate other iron preparations. The prophylaxis, the WHO recommends prophylaxis of 60 mg iron and 400 mg folic acid. But according to the Ministry of Health and Family Affairs, we are all giving 100 mg iron with 500 mg folic acid for 100 days, starting after the first trimester, 14 to 16 weeks, and also postpartum for another 6 months. The same dose is continued. So it is important that they continue the dose postpartum to replenish the deficits. In pregnant, after achieving the normalization of the hemoglobin, the prophylactic daily iron supplementation is recommended for at least 6 months during pregnancy and should be continued in the postpartum for 6 months. The response is based on the reassessment of the reticulocytosis and the hemoglobin levels. And in people who have not responded adequately, oral iron therapy they should be treated with alternative iron. We have to transit to either IV iron supplementation or see how we can take it forward. The challenges here are mainly the GI side effects, that is the nausea, flatulence, abdominal pain, constipation, black stools, reflux esophagitis, poor absorption due to interactions, and even sometimes some other drug intake like NSAIDs or salicylates. We need to see what are the medications they are on. And non-adherence is to 75%, treatment failures and unnecessary follow-up investigation, and slow improvement in hemoglobin levels. Therefore, parenteral iron could be a better option in treating these patients who are not compliant. To summarize, oral iron supplementation is the first line treatment during pregnancy. GI side effects can lead to suboptimal patient adherence. Therefore, parenteral iron is seen to be an attractive option in the treatment of iron deficiency anemia. Thank you.
Thank you, Dr. Rekha, for a wonderful talk. I think you gave us a beautiful overview of what are the Government of India guidelines and also how we've come a long way since the original, ferrous fumarate preparations, which we used to avoid like the plague because they used to cause so much GI upset. Over the past 2-3 decades, I think technology has taken us quite far, where we have good bioavailability, good tolerability of oral IL preparations. I'll invite Dr. Meghna Madam because she's still around. Madam, thank you for sparing your precious time. Can you give us some insights into how the government looks at this Anaemia Mukt Bharat campaign and how far you think we have come as far as resolving this problem in the interiors of the country is concerned?
I think we have progressed a lot, and especially I liked your presentation about the 6 into 6 into 6. That is a best strategy because you are targeting such a huge population. And with this government, this RCH program, including which I already mentioned, deworming, then the direct, there is also a very good method of giving iron tablet directly, like TB. And the TB medication, when the patient used to throw it away, now they are seeing to it that they are giving it directly, DT, direct introduction to the patient. And also third very important thing is they are involving the Say program, that is the children program, then the other children related. So children, mother, and all this program, combined together is making a very, very big impact. And I think what you said, Pratik, that this because of lowering of the this anemia, the rate lowering is around 20 to 30%. Still, we have a long way to go. But I think this is going to be a major, achievement of this government. And also the previous, we are there since so many years as a deputy director, RCH. So the continuous efforts has made a definite impact, and you can see the rate of maternal mortality, which is already lowered because of the improvement in the anemia. But still, we have far way to go, and I think we will carry forward this program very well.
I think after Kerala, Maharashtra is number 2 all India as far as maternal mortality is concerned. We've made huge strides over the past decade or so. Thank you very much, Dr. Meghna Madam, for being here today, and we wish you all the very best. We hope to see you as Foxy President very soon. I'm sure Anaemia Mukt Bharat and many other government programs will be the focus of your year once you take over, as and when you do take over. Thank you so much, ma'am, for gracing the occasion, for being here throughout this program, and for all your blessings so far for our program.
Thank you, Vasav. Bye. Like I bolat hote, Pratik?
Yes, ma'am.
You were saying something, no?
No, I was just introducing Dr. Sudesh Doshi, sir. Sir is who's practicing years in a semi-rural setup in Pandharpur. He's a zonal coordinator of AMOGS, medical legal chairperson of AMOGS in the past, and somebody who is looked up to very much by all of us who are following in its footsteps. Thank you, sir, for joining us. You've raised your hand. Please go ahead, sir.
Yes, thank you, Dr. Pratik.
Pratik, Sudesh, yes, and I had the privilege of working with him since last. I went to Pandharpur, I went to Kolhapur, and again Satara. Wonderful speaker, and what he speaks, directly it appeals to the masses. whether it is a MTP or, a very practical subject. And I saw people engrossed in his lecture whenever he's talking. And I think that is the success of his, carrying forward the message of EMOX and also very practical tips. So keep it up,
Thank
Dr.
you.
Sudesh Joshi.
Thank you so much. Thank you so much, Dr. Mandakini, for those kind words. Well, I had raised the word about anemia. I also went through the lecture, though I joined a little late. But yes, anemia is an important problem. And we at all levels, government levels, private practitioner level, we all are tackling with it. But one thing which I found it, which is missing with our private practitioners is, though government has recommended routine deworming at around 20 weeks, 1 tablet of albendazole, it works wonders. We are giving iron sucrose, we are giving sulfate salts, ferric salts, all things. But one thing which is missing from our private practitioner lines is albendazole. So I have been practicing this for last almost 15 years. When I come to know about this program, I would recommend strongly to all private practitioners to add a single tablet of albendazole in your prescription at around 20 weeks, which will help patients for eradication or deworming. And as Dr. Mandakini said, giving tablet directly to the patient. I do practice that around 20 weeks when the patient comes with the anomaly scan. I give the patient tablet free of cost from my side. It is only 2 or 3 rupees, doesn't cost much. And I ask the patient to chew it in front of me so that I know that she has taken the tablet. And it helps to form a good rapport with the patient. Patient thinks that doctor is caring for her, and definitely it is a good gesture. So I would recommend, especially for private practitioners, to include 1 tablet of albendazole at 20 weeks, which will help a long way in anemia. Thank you.
Very important practice point from Dr. Doshi. Thank you very much, sir, for that important remark. We have with us Dr. Basab Mukherjee, sir. Sir is here to speak to us about a novel and exciting molecule, which is iron isomaltoside, which is going to revolutionize parenteral iron therapy. For his formal introduction, Ganesh, can we have the CV on screen, please? I would request our chairperson, Dr. Sudesh Doshi, to please do the honor.
Yes. Well, it's an honor to introduce Dr. Basab Mukherjee. As we know, he has done his medical schooling from CMC Vellore. He is not only at local level, but also FIGO level. He was FIGO coordinator of South Asia of Safe Abortion Community, clinical examiner for RCOG examinations in India, member of Governing Council ICOG for 5 years, honorary secretary of Bengal Obstetric and Gynec Society, Young Gynecologist Award of AOFOG 2011 at Taipei, past chair Family Welfare Committee of FOXY, Vice President Election FOXY 21-22, and organizing secretary of AICOG 222. We had a wonderful conference at Kolkata. Thank you, Dr. Basab, for that. And the dais is yours. Dr. Basab Mukherjee, please.
Thank you, Dr. Doshi. Thank you very much. It's a pleasure being here. If you have friends like Dr. Pratik Tambe, you will be getting invited to AMOG's sessions multiple times. So thank you, Pratik, for inviting me yet once more. And it's just an absolute pleasure being here. Meg, Madam, Namaskar. It's always so happy to see you and seek your blessings. And we are all with you in your endeavor as it keeps on coming closer. So over the next, I'll just share my screen. Yeah, so I think just a few thoughts before I take it forward. One is the thought which I always we discuss whenever we talk about anemia. The NFHS is one of the most renowned government documents where we have an incidence of things happening in our country. And the NFHS 5 keeps on showing that anemia is still a really major problem in our country. And if you look at the community programs which the government has spent crores and crores on over the last 6 decades on anemia, we still find ourselves short, that we still haven't been able to conquer the disease. Though the maternal mortality, of course, has come down, but the anemia as a disease or anemia as a prevalence remains more or less same. But I like the way Dr. Rekha said that when you breaking up the states and you're taking a few of them who've done better than the other ones, then what have they done differently is something which is really worth looking at. And what seems now is a multi-pronged approach. As Dr. Sudesh Doshi said, you have the albendazole, you have the fortification, you have the oral iron, you follow it up, you keep on checking it, do your antenatal visits. And I think it's a multi-pronged approach that works best, and there's no magic difference that something can do. But sometimes we usually wonder, I think, whether diet has a lot of things to do in India because of a carbohydrate-rich diet and a phytate-rich diet and the tannins, whether that has a role in interfering with iron absorption is something which possibly can be a thing of research. Also, the Indian GI tract, whether that's a little different in absorbing iron than the other GI tract is something I think is worth looking at. So one of the different methods of coming out of anemia or conquering it or trying to beat it, besides the Anemia Mukt Bharat, which has been a massive program by the government, which we are all supporting at FOGSI and looking forward to how the change is happening at the ground, is the role of parental iron. So parental iron has been in the vogue for at least 10 to 12 years. We have had talks on parental iron at different forums. It all started with iron sucrose and then FCM, and now this new molecule which is there, which I think we will have some more discussion over the next 15 to 20 minutes. So parental iron is when there is a poor tolerance to oral iron therapy. And what we keep on reiterating at every discussion is that you have to start with deworming, and you have to start with an iron-rich diet before you go on to oral iron, and only after that does parental iron come into the picture. Though there are some of our luminaries in FOGSI who do recommend that in 3 trimesters you give 1 shot of parental iron in each of the trimester, and that will cover it. You don't have to rely on her to have oral iron, but still I think we do understand that iron-rich diet and oral iron therapy does remain the rock solid first line of treatment, and after this would be parental iron, but that would not be a replacement at any time soon to oral iron. So whether it's poor absorption, whether it's non-compliance, whether it's poor tolerance, there are several issues of oral iron where parental iron will come into the picture, and there is a definite role where you have to see where you can give it or how it can be administered. So whenever there's a new parental iron in the market, that would stimulate interest, because recently we have heard about anaphylactic reactions happening with parental iron. Of course, it's much less than what used to happen in the iron dextran days, but at the same time, whenever you're giving an iron preparation, you have some anaphylaxis of varying degree, sometimes mortality, but often morbidity. It is something which is unwanted, and you would like to, of course, avoid that. A few points or tips there is oral iron should be stopped at least 24 hours prior to therapy to avoid a toxic reaction, and you would restart 1 week after the completion of the full treatment of parental iron, not usually before that. So first of all, a prerequisite of parental iron is, of course, confirm the diagnosis of iron deficiency anemia. As Dr. Rekha very nicely in her presentation said, that anemia can be of different types, and only if it's iron deficiency, which of course is the commonest, then you need to give iron supplementation. So whether it's diet, whether it's oral, whether it's parental, you have to give, if it's an IDA or iron deficiency anemia. And then, of course, if there is because a parental iron is still emerging, and you have to have some sort of a management of anaphylaxis ready, though it's very rare, less than 1 in 1,000, possibly even less. But at the same time, you need to keep things in mind. Sensitivity test prior to infusion recommended, not done. We'll talk a little bit more about that as we go forward with this presentation. And the contraindications, of course, if there is a history of prior anaphylaxis, first trimester of pregnancy, we try to avoid most of the things. Chronic liver disease, active infection, then of course you would like to avoid it. So calculation of the dose of parental iron, well, this is especially if you're giving the full dose together. A lot of us like to give it in parts, but it's good always to know what is the deficit so that you know how much you really need to cover if you're covering it. Because when you're giving parental iron, in most cases, you're giving it instead of oral iron, and you would try to cover as much as possible in 1 shot, if possible 2 shots, and then to know how it is. So 2.4 into the target hemoglobin, you put it as 14, 15 minus the actual hemoglobin into the pre-pregnancy weight with 1,000 mg addition for replenishment of stores. So the story of parental iron, as most of us would have heard, or most of it was more than 20 to 25 years, I think, from the time that I was in undergraduate days 30 years ago, we did hear about iron dextran. And then we did, as we passed out, iron sucrose came into vogue early 2000, and middle of 2000 to 2010, that was iron sucrose, which was a time. And then slowly FCM took over the market last 7 to 8 years possibly. And now it's isomaltoside, which is the new iron molecule, which we will be talking about today and how it's different. So parental iron, the classification depends on the type of complexes. 1, 2, 3 thermodynamic properties are here and examples are there. We'll come to more details later. The intramuscular preparations are no longer used. So you can talk about historically. So this is how it was there when it used to be there. It was a painful injection. There was discoloration of the skin, chances of abscess formation, and that's why it's gone out of vogue. And now it is almost never used. So what we're talking about is only IV iron usually. Mild to moderate iron, how much do you want to give? So this is just a comparison of the number of doses that you need to give if you're giving the different salts of iron as a parent in the parental form. So if you're giving iron sucrose, because of the limitation of the total number of doses which you can give, you have to give it in 7 to 9 doses for a mild to moderate, and even more than 10 for a severe deficiency. If it's FCM, of course, you can reduce the number of doses. And with the new iron isomaltoside, you can even lower it further. So the basic idea is getting maximum through minimum. So one visit or one OPD visit would possibly take care of most of the deficiency. If you calculate it well, give it well, and that can be done. So iron, so how does IV iron, what is the composition? It may be a good idea to go a little bit through that. So just giving the very nice diagram on the left side of the screen where you see iron 3-oxyhydroxide oxide core. So that's where the iron element is. And there is a carbohydrate shell outside, which will take it past the gastric acid and the GI tract, directed towards the reticuloendothelial system, where the actual breakup will happen. So every parental iron is complex with the carbohydrate moiety, which holds on to the iron till it reaches the liver and spleen, and there it is going to be released. And if the iron is released earlier, then there will be labile irons, which are not very good. So what are labile irons? How are they harmful? They are free irons released from the complex after administration. So it's broken down before it actually reaches the reticuloendothelial system. And these free irons are responsible for a lot of the side effects of parental iron, namely hypotension, hypersensitivity, oxidative stress, cytotoxicity. And so we would like to have a product which would have the least amount of labile iron, and isomaltoside seems to be one of that, which is the new kid on the block. So how has it low iron potential? Because it is a strongly tightly fixed structure. The matrix is very tight, and that is the reason why it doesn't break up so early. It breaks up only where it's supposed to. So controlled and slow release of iron, and this is tries to avoid the potential toxicity of labile iron. So labile iron is something which we never heard much of, but with the parental iron in picture and with the new product in picture, you can understand, seeing at a graphical representation of the bar diagrams, that the new salt iron 3-isomaltoside has less amount of labile iron in this study published in the American Journal of Hematology compared to ferric carboxymaltose, which most of us are now using now, and iron sucrose, which most of us used at one point of time. Also, we're using now, possibly sometimes for cost, sometimes for thing, but it's much more than a carboxymaltose. So here is the maximum single dose. Again, as you said, see, you can give more with less. So iron isomaltoside, you can give a large amount with a less amount of dose, and you're covering more than you're covering with sucrose, of course, and also compared to FCM. So it's the only IV iron with no upper limit of IV iron administration dose. There is an upper limit, we'll come to it later, but generally it's much more liberal than the FCM before. And it is a third generation IV iron compound. We showed it to you before. And there are approvals which have already been received in Europe, in DGCCI in 2013, nearly 10 years ago. And now it's just come up now, and US FDA in Jan 2020. So it's reasonably well researched, well studied, and has been given the nod by all the nod agencies, which you need to have a nod before you come into the market and you establish yourself as a good brand. So parental iron isomaltoside, it's absorbed by the reticuloendothelial system cells, as we said, the liver and the spleen, where it's split up and the iron binds to the protein, forms ferritin, replenishes iron store, and that is how it exactly works. So some of the clinical evidence which has come out from here. So the first set of evidence is the comparison with iron sucrose, which in my opinion should not actually be there, because you should be actually comparing it directly with iron FCM, which is there in the subsequent set of slides. So the initial slides as iron isomaltoside versus iron sucrose. And here there's a set of 1,500 plus patients with IDA who had GI and gynecological blood loss. And here the number of visits, of course, you had less visits with isomaltoside, and had a hemoglobin rise of 2 gram%. So that is one thing which was noted here. And the single infusion, again, continuing with the same study, about the hemoglobin rise was slightly higher in isomaltoside after 2 weeks compared to iron sucrose. And proportion of women also, there was a significantly higher rise of women who had increased more than 2 grams. That was quite fast at 2 weeks time. Then again, a study from American Journal of Hematology, and this is a randomized trial with, again, isomaltoside and iron sucrose. Here, the number of patients, again, with this also is showing the number of patients with a faster rise in hemoglobin at a shorter duration of time is with the newer salt than the older salt. And it all happens in 26 days is what here we have seen here. So superiority in comparison with iron sucrose, I think we've already mentioned this. We don't need to repeat this. It has less labile iron, does not require a test dose. Iron sucrose also, I don't remember us giving test doses, but we used to give the initial part slowly and then fast. So iron isomaltoside versus FCM, well, this is where the crux lies. Like, you always need to compare with the golden standard or whatever the most commonly used molecule of that time. So once you want to make a competition, or once you want to establish yourself as a superior salt, or possibly more reliable salt, you would need to compare with the one which is most commonly used now. So drug safety, this is a new concept of hypophosphatemia, and this is has a higher risk with FCM. And this is so we're just trying to get through the physiology here. There's something called fibroblast growth factors, or FGF, and this is already there in iron deficiency, and also it increases in ferric carboxymaltose. So what does FGF do, and how does it cause hypophosphatemia? Well, it leads to reduced phosphorus levels, vitamin D, calcium absorption. It works mainly at the kidney, at the renal level. So here it's where how it works. It inhibits the reabsorption of phosphate in the renal proximal tubules. And as that is done, more phosphate goes away from your body through the urine. So that's hypophosphatemia. How does it work clinically? Well, clinically, you can have generalized weakness, fatigue, respiratory depression, just symptoms of anemia again coming back even after giving an IV iron injection. So how much is it clinically relevant? How much do we see it in practice is something which we really have to look at it. But hypophosphatemia is definitely studied as one of the risks of FCM, which is more than the risks associated with the newer salt. So drug safety, phosphatemia, here there is studies where they have, this is published in the JAMA 2020, significantly more pronounced drop in plasma phosphate from baseline in patients receiving FCM than iron 3 isomaltoside. But again, how much is that clinically relevant is something also very important. It's not just the biochemical factors that we need to consider. And here you see that the phosphatemia is compared to the isomaltoside is quite high in FCM in both these trials, which have been done, published in JAMA with 245 patients. No changes in vitamin D and calcium hemostasis with isomaltoside. Severe hypersensitivity reactions, 0.8% in iron isomaltoside, 1.7% in FCM. It could happen to anybody. Again, you need to get prepared for things like this. Most of the times it is transient, but again, sometimes it may be serious, which needs medical attention. So FCM induced changes in vitamin D, calcium homeostasis that triggered secondary hyperparathyroidism, likely to contribute to the persistence of hypophosphatemia. It may go on beyond the duration of your administration, or beyond it's last longer. Isomaltoside versus FCM indirect treatment comparison, cost and effectiveness. Well, here, as you have to give possibly more than one infusion, your cost will generally be more than if you want to give one. And here it is a comparison, and they have so calculated cost per responder and number needed to treat to avoid a single infusion. And this is again what they come up with, 910 for FCM and 580 for iron. I think this was in UK, so I think it's in pounds in the GBP, and that's the difference. So conclusions that they made from this cost-effective study is that the iron-3 isomaltoside, other than FCM with patients with IDA, was dominant and would reduce the number of iron infusions required to correct iron deficiency, reducing the cost associated with IDA treatment and simultaneously increasing proportion of women with IDA experiencing clinically meaningful hematology response. Now, it's quite ironic that for an anemia study, we need to look at United Kingdom for comparison of these two salts, where we have so much of anemia in our own country. I think it's time that the company keeps on giving a few samples for thesis of postgraduates in our country, so that we can generate some data of our own, which I think would be much more accepted and much more ideal in our setting, and see how exactly it features. So how iron-3 isomaltoside is superior to ferric carboxymaltose? Well, here it is. It's less labile iron, as we said. This is a new concept of labile iron, which is the free iron, which has come out from that carbohydrate shell, which you had seen in this initial part. So that is more in ferric carboxymaltose than the newer one, isomaltoside. So that is something which is a plus point there. Iron deficiency correction in a single visit. Most of the time, FCM also can be done in a single visit. Sometimes you may need more than one, but generally that is how it is. There was one point of time where a lot of reactions were happening because of the infusion, which we were given slowly, but now we understand that it has to be over in 15 to 20 minutes for the best results, and you're having a less chance of complications. So various segments it's been studied. Chronic kidney disease, of course, ONG, and oncocardio, inflammatory bowel, and things. During pregnancy, what are the studies? That's a very important aspect. And here it's a category B drug. Whether we have studies and surveys, I'm not sure, but it's category B, so it should be all right. There's 21 prospective trials using 8,000 patients for iron-3 isomaltoside, FCM, and retreat for hypersensitivity. It was lower in the new salt that compared to the older salts. And of course, that's the reason why you've got the FDA approval. That's the reason why you've got the DGCA approval and all the approvals required. So 213 pregnant women beginning of the second trimester, and until a few days delivery, so it was a range, and they all got a single dose of iron-3 isomaltoside. This is published quite early, 2017, and it was safe, which I think is safety, convenience, efficacy, and negligible adverse reactions. Postpartum, of course, this is a very important part of the pregnancy period, and I think all of us do we speak about postpartum anemia and the postpartum care in general. And I think it's so important that after a delivery, whether a normal or a section, you have to have the hemoglobin checked, and you have to do some correction before the woman leaves the hospital. So that is, so when we talk about contraception, that's one way. And we also need to talk about anemia, because you have an option there where you can intervene. And if a person is non-compliant or poorly compliant, you have an option which you can give her of just continuing the IV drip with a parental iron, if that is what she wants and if that is helpful in her, because she needs to have a fair amount of hemoglobin when she's breastfeeding, because you need to understand that also affects the baby, the breast milk iron content there, and there are several issues on that regard. So here there is a postpartum period fatigue, and here you have here there's a study on oral isomaltoside versus oral. So oral, as I said at the beginning, is always the gold standard. That is what will come first. But there are people, a sizable number we see in our population, who either are intolerant or are poor compliance and or have definite side effects with oral iron, where they want alternatives. It may come at a price, but some people are often, a lot of women who are willing to pay that price and to have a benefit, which if you can extend to them, we may have a very positive effect on them. So single dose isomaltoside in a postpartum period also. So we spoke about antepartum after the first trimester, and also postpartum has helped in having an effect. So 200 women with postpartum hemorrhage, single dose IV infusion. If you're doing it instead of blood, that will be good. If you're doing it with blood also, okay, but as long as it does its thing. Again, as I said, 2 times higher iron in maternal milk. So I think that's also an important thing. Once you diagnose a person with postpartum anemia, you need to really correct the anemia early, because she has to, because it's important that the iron content in the breast milk also is not affected. So the first 6 weeks, if you take for it to wait to increase, you may lose on time. And so it's important that we correct it early in after a delivery setting. So here, a single dose IV iron versus red blood cell transfusion for severe postpartum anemia. And this IV iron could be an alternative to red blood transfusion. Yes, that is one thing. Again, you can give those options also, because blood transfusion has its own effects. So this is a dose calculation. I think we'll skip that. And this we have already discussed. And here, I think this we'll skip and we'll go directly to, oh, sorry, I'm going backwards. So IV had an infusion of iron isomaltoside up to 20 mg of iron per kg body weight, or as weekly infusions. And then you can split it into 2 parts, and you infuse undiluted, very much like FCM. You can give a slow IV shoot as long as you know it's in the vein, or you can dilute in sodium chloride. That's give it over 15 to 20 minutes and make sure that it goes in fast, and you have a very nice IV line out there. And so that's the idea. Blood transfusion, yes, that's one option, of course, and that is an option when you don't have time and the patient is already coming with a congestive heart failure and with low hemoglobin. Of course, there is no alternative to blood and blood products. Same thing if she's in acute PPH or some severe bleeding, you need to settle it, of course, with blood and blood products. You don't have a chance of giving parenteral iron at that point of view. Risks of blood transfusion, we all know, and that is something which you like to avoid. And that's the reason why for any chronic setting, I think we have an option of parenteral iron. So just summarizing the discussion we've had here, friends, IV iron use in women of reproductive age has increased rapidly. And a lot of our gynecologist friends, a lot of people who have tuned in here are responsible for that, because we in our clinical practice have understood that this is an option which we have to give to our women, and we have to use it in certain cases for the best interest of the women. And also any new salt which comes in this regard stimulates and triggers of interest. So iron 3 isomaltoside is a new IV iron, which can be given as 1000 mg and above in a single visit. It has faster, more predictable arise compared to iron sucrose, of course. In some instances, comparable to FCM. In some instances, slightly more than FCM. There's no test dose required, which we don't give in FCM either. Possibility of a full iron repletion in a single infusion, which is often done, and acute anaphylactic reactions or delayed allergic reactions are not very much seen in clinical observation trials, but we need to be ready for everything. So it's a safe, effective, and convenient approach, which we can give an option to our patients as something new and something more effective as it stands now. So low immunogenic potential, low potential, no test dose, category B in pregnancy, as we see. And then overall less treatment cost if you take everything together, if she doesn't have to come twice, and predictable hemoglobin rise. Thank you very much. It's been a pleasure. Thank you.
Dr. Sudesh Doshi, sir,
Yeah. Thank you, Dr. Basap, for that exhaustive knowledge of our newer IV iron. Iron has always been there in the market since 1960s. We are always trying to improvise. The government also has accepted the changes. Previously, when we were colleges, we used to know that government only used to do ferrous sulfate. But now the government also make iron sucrose available, and it's very much available in all PHCs. It is improving anemia. The newer iron definitely is a good prospect. We will have to try it out. We will have to look at it, because every time a new product comes into market, it is always like what we say in Marathi, "Akudshingi bahududi gai ahe," असं सांगितलं जातं. But then the newer one comes again in the market. Yes, definitely it is a good thing. We will have to try it in the market on the patients. And as our experience goes on, we find it fruitful, we will use it. Also, over the time, the price factor will also come down. As we know, the newer products are always costly. So as soon as it becomes affordable and we all use it, it would be definitely a new armamentarium in our basket to use against anemia. Thank you, Dr. Bosa, for it.
Thank you.
Thank you, Dr. Sudesh Doshi, sir, for your expert comments. I have just one small slide to share, and with your permission, I'll just share my screen.
Yes, sir.
Dr. Basam Mukherjee was saying that it's difficult to get Indian data for most clinical scenarios these days.
Yes, the irony, it's the irony in an iron situation when you get data from UK for
anemia in UK, when we have like tons of patients here in India.
Yeah.
This is one slide which I have regarding the recent Indian experience. I think this is updated up to January of 2023. 49 clinicians have used this particular molecule, I3. Nearly 400 patients, and the rise in hemoglobin is substantially good, and it's shown very good efficacy with zero anaphylaxis in this small series of about 400 patients. So I think that's something which is significant. That being said, we need to have more data, we need to have larger volume, plus we also need to have multicentric data. And for anybody who's logged in, I think we have nearly 800 viewers who are logged in live today to listen to a program on anemia in the afternoon, which is something, unimaginable. 800 people still, even in 2023, want to learn about anemia. Yes. So if any of you wants to conduct a clinical trial, you're most welcome to get in touch with us or our academic partners, Glisten, who are the makers of injection I3. I'm pretty sure they will be able to come to some sort of understanding and help you out as far as the costs are concerned, and helping you out regarding the conduct of the clinical trial is concerned. We welcome more and more people to use this new molecule, because unless it is used in our Indian patients, we will not know what is the efficacy. We will not understand what are the issues, the practical problems that all of us will face in clinical practice. So thank you very much. I see Dr. Rekha is back. Her video was off for a while. And we have 2 or 3 questions which are coming from the audience. So we'll just take those for the Q&A session. The first is from Krishnagiri, Dr. Rekha. So I'm pretty sure that is for you. And the question is asking, this is from Dr. Venkatalakshmi. What is the role of parenteral iron as far as antenatal anemia is concerned? I think it's been answered already by Dr. Basa, but since it's from your own society, I thought you might want to take it. Can you please unmute, ma'am?
When the patient, like when Basapsa told, if the patient is non-compliant or if they have other GI side effects, parenteral iron is the drug of choice. And now with I3 coming in, I think most of us are using FCM, but I3 also can be an alternative. And I think all of us should get in with the clinical trial and use more of I3 if there are less side effects. Yeah.
Thank you. There's another question from Dr. Surabhi Ramaswamy. She's from Dharmapuri, and she's asking, is there an easy HB estimation home kit which is available? Now, this is another practical issue probably for primary health centers and for the interiors where access is poor. There, where they want to quickly triage a patient, whether this patient needs parenteral iron, this patient needs admission. That's probably
There's a new digital hemoglobinometer, which some of the companies are promoting, but how much is it, or how can the patients procure it is a big question. It's still cheaper to do it in our labs. Just if you're going to do only hemoglobin or CBC, it's not going to cost more than 200 rupees in our setup, where we are all in the periphery. So 200, 250 will be the cost. I think they can afford that CBC.
Thank you. This is a question from Dr. Zoya Khan in Jabalpur, and she's asking, what are the causes of anemia in teenagers these days? I think this is something which you will hit out of the park for a 6. Basant, any comments?
Anemia in teenagers. Well, that's very interesting because we talk about malnutrition of a different type also. So the malnutrition we used to talk about, generally you think about Africa, you think about a rural area, you think about people who are thin, people who are malnourished, but there's another malnourishment of the other sort where you are not having the nutrients which you need to have, you're not having the food which you need to have. The fruits and vegetables are missing from the diet, and it's all filled with carbohydrates and things which your tongue invites you, and not your heart, not your heart and your brain. So I think so there are a lot of dietary problems in adolescents which are one of the causes of anemia. They hardly have their health checkups done. That's one of the things. About worm infestations and malaria, the incidence is more or less same in adolescents and adults. I don't think that's a difference. But I think food is definitely something which we all can get educated in, food which is iron rich, because dietary wise, I think most of our gynecologists are quite poor, especially in an urban setting. In a rural setting, they must still give some good quality advice. But personally speaking for myself, I think we are not very well dietary trained to give a very basic advice about iron rich diet and things about that. I think those are things which are very important that we need to get ourselves clear with. Dr. Rekha, if you want to take that adolescent anemia, what you would think?
In these children, recently we've seen a lot of obesity, then the type of lifestyle and food. Hypothyroidism is on the rise, and the anemia due to hypothyroidism is also one of the causes. And in case of these patients who are either PCO, the inflammatory process also has a decrease in hemoglobin levels. So I had mentioned in one of my slides, the inflammatory causes of anemia also is there in the alternative reasons for anemia. So I think mainly lifestyle changes, dietary improvement, and then substantial supplementation of iron deworming, and regular counseling and coordinating with the patient and mainly the parents need to be educated in these cases, where they need to understand that they don't go by the children's tantrums and give them a proper balanced nutrition. And as part of our clinical work, I think we should counsel them regarding the diet rather than sending them to a dietitian, because they wouldn't take the dietitian so seriously. So we need to create an impact on them, saying that diet and management in diet is the first choice for these children.
Thank you, ma'am. Thank you very much, Basab. I think you mentioned it, that the Indian carbohydrate-rich diet with lack of protein, excess of phytates and other minerals which inhibit iron absorption is also a very important causative factor which we neglect to talk about. The next question is from
Dr. Doshi wanted to make a point. Pratik, Dr. Doshi wanted to make a point. Yes, Dr.
Yes, sir.
Yes, sir. About food fats and everything, sometimes as we see, the junk food contains less of iron. But one Indian food which we all love is good or shengaka laddu, that is groundnut and jaggery laddus. They do have a cultural value. They definitely jaggery gives the highest amount of iron. So this can be incorporated in their style, either as a chikki, either as a vadi, or a good shenganika laddu, and that will help in iron, because food fats, I know, difficult to break it. But shenganika laddu is a favorite of all, and everyone can have it, a good protein and iron diet.
Thank you, sir. Thank you very much. The next question is from Dr. Jitendra Kumar Nath from Morigaon in Guwahati. And sir is asking, in case of congestive cardiac failure with severe anemia, probably this patient is admitted, what is the correct approach to correct the failure? Do you give transfusion? Do you give parenteral iron? What exactly would be your approach? I think, Basab, this is right for you.
Yeah, so I think transfusion does work best or fastest, of course. But again, as you know about congestive cardiac failure, the little medical knowledge that we all had during MBBS and MD is that you need you're afraid of a fluid overload. So obviously you'll be giving the whole blood is gone nowadays. So packed PRBCs is what you will be using. Of course, you'll be using possibly diuretics along with that. So you flush out the fluid out of it and get the most concentrated RBCs in the system. So that would be an immediate effect. But again, if it's along with other things, you may give oral or parenteral iron as a top up, but your immediate priority would generally be PRBCs to correct the anemia immediately and to have the relief of symptoms. It depends on what setting you are doing. If it's an admitted patient, a hospitalized patient, of course, it's much more easier. to do that. If it's not a patient who's admitted with a CCC, I think they should need an admission and then to be tackled this way. But blood products, of course, would be the thing of choice. And here, the oral and parenteral are mainly for a chronic setting and not for an acute setting.
I think another key point is that probably you don't do a complete correction with blood products, packed RBCs as well, for fear of overload. Maybe you correct up to 7 or 8 grams, and then the rest you give a top up with parenteral, and that would probably be the way to go for an admitted patient. Of course, everything depends on how much time you have until she goes into labor. Sometimes the act of just giving transfusions, I remember in the good old days, patients who go into labor 24 hours later after you had given the blood transfusion. That's something which is unpredictable and something which is not within our control as well. One last question we have, this is from Dr. Vijay Kumar from Daudnagar. And I think, Basant, this is for you. When platelets and RBC are down along with HB, then what would be the management? I think he's talking about pancytopenia.
Yeah. So I think, so if your platelets are down again with, so again, you have to look at the counts. So a pancytopenia, typically we know from our medicine days, there are 3 wings. So one is the RBC wing, one is the WBC, and one is the platelet wing. So putting it simply, if all of them is down, then you think of some bone marrow suppression or things in those lines. Obviously, at some point of time, a hematologist will be in the picture. You will not be able to tackle it together because we have limited expertise in this field. So either a medicine doctor or a person of a hematology background or a hematologist would generally be brought into the picture, or would be referred, the patient be referred to somebody like that. But till then, if you want to have a correction, again, depends on the setting in which you have them. If it's an outdoor setting, of course, you'll start with oral hematinics and try to build it up, give a protein supplement along with that, because that's something which is very good for a boost, which often we don't do. It's not just to limit up oral iron and deworming. You need to give a protein powder also along with that. That gives a good boost. So those are the things which you'll do. Possibly you repeat the values to make sure that it's right. You need to repeat it from another lab, possibly a more reliable lab, your NABH accredited lab, let's say, and then those are the things you'll do. And you will also do possibly other parameters which we know are like the serum ferritin, the peripheral blood smear, to have the CBC, again, a complete view of the MCV and MCHC. As Dr. Rekha very nicely pointed out, there's different ways of which you can find out what you have before you're sending her up there. So those are things. Also the drug history, what medical drugs she's on, because that's one of the reasons of bone marrow suppression, a lot of other things to keep in track. A nice peripheral smear to see whether there's anything to be seen there. These are some basic things back to old days of medicine, which should have some idea or some direction. Either if she doesn't have a hematologist anywhere near, she doesn't have a medicine doctor, she's heavily relying on you, or there'll be time for when she reaches there. So these are some basic things I think from my end I would like to do before, I think. Dr. Rekha, you'd like to come in? Is there anything else you need to add?
Ma'am, you're muted. Please unmute.
In this patient where the platelet is also low, I think we need to also rule out other infections before starting on any other evaluation. Because if it is a viral infection or something, if they have had a recent viral infection, this picture can be there. So probably we'll give them another week or 10 days time and reevaluate and then take it forward.
Thank you, ma'am. And there is a sub question to this question. If the HB, RBC and platelets are down, but the TLC is high, patient has excessive weakness, what could be the issues? I think we would be looking then at something like leukemia or a lymphoma, AML, CLL. If my memory serves me right, my undergraduate hematology.
Again, Pratik, like it's again, we're not really skilled or trained to talk about that. I think, like exactly. At some point, it's quite early in the days, he would have been referred to a medicine or a hematologist. So let's not talk.
Look at the details. So I think that's the end of the questions. We've had a fantastic, engaging session today. We have nearly 900 viewers live. Thank you so much to both our respected speakers and our chairpersons. Any closing remarks before I propose the official formal vote of thanks, please? Dr. Rekha, Dr. Sudesh, Dr. Basant, anything?
So preventing anemia even among doctors and our educated and literate people is still a Herculean task. Sir. I think we as doctors first need to take care of ourselves and people around us.
Don't listen to other doctors, man. That is the problem.
Yeah. So, no, I'm seeing a lot of our younger doctors who are coming to us. They're post-MBBS, PG students. they're also very severely anemic. I think it's our fraternity that needs to be looked after first before, implementing it in the society and other people. So as a team, we need to work. Yeah, we need to self-care as a point of care first and then take it forward.
Yeah,
this is something I want to tell.
Yeah, the recent craze generally has been vitamin D3. So vitamin D, a lot of people are doing, and that's a craze recently. But anemia has gone to the back burners. We're not talking about hemoglobin or CBC anymore. So I think you just add a CBC to the vitamin D3. I think that would make it perfect, where you can just find out both, because vitamin D is a fad now. Vitamin D3, everyone's doing vitamin D, and you just love to pop in a tablet once a month or once in a week, and that's thing. But I think you're right, Dr. Rekha. We are hardly checking our hemoglobin for people who need to do it. So,
and the other thing is about diet, sir. A lot of our food around our house, like in the rural area, we have this moringa leaves available and greens available very easily. Just that they can take that regularly every day, weekly, 2 times or 3 times. That itself, their diet, proportionally, the diet should change. I think the diet implementation is something all of us have to emphasize.
And also in a vegetarian setting, a veg setting, it's really, really just a scramble for your iron in the food. In a non-veg, at least you're getting it default, but in a veg setting, you have to really scramble. Because
and the new fad about being vegan also is getting
being vegan is again, that's a fashion, being vegan.
It's not social media to talk about these things anymore.
Some other time, some other day.
Yeah. Okay.
So thank you very much to both our esteemed.
Thank you
very much
for giving us this opportunity.
It's a pleasure.
Thank you, Amox.
Thank you.
So I'll just propose the formal vote of thanks at the end on behalf of the AMOG's Endocrinology Committee. This is Dr. Pratik Tambe. I'd like to express my gratitude to the AMOG's office bearers, our President, Dr. Rajendra Singh Pardeshi, sir, Secretary, Dr. Sujata Davi, the ICOG office bearers, our Chairperson, Dr. Lakshmi Shikhande, and Dr. Ashok Kumar, our Secretary. Thank you for the ICOG credit point. Two excellent chairpersons, Dr. Sudesh Doshi, who is our zonal coordinator of AMOGs, Dr. Sarita Bhaleta, who is a governing council member of ICOG. We had Dr. Mandakini Meg, a past chairperson of ICOG and candidate for President Foxy, who came in for quite some time, gave us a lot of her expert comments. Two excellent speakers, Dr. Rekha Rajesh, president of the Hosur and Krishnagiri societies. Thank you so much for being here and speaking on Anemia Bharat and Rural Iron. And of course, our star speaker for today, Dr. Basar Mukherjee, past Vice President of Foxy, for talking about parenteral I3 and how it's going to be a game changer as far as treatment of anemia is concerned. Thank you, everybody who's logged in today. We have nearly 900 viewers across the country. And of course, I must place on record my gratitude to Science Integra, Subbu, Ganesh, and everybody in the backend team who does a lot of hard work for all this experience series with the AMOG's Endocrinology Committee. Last but not least, I need to also place on record my gratitude to Glisten Pharma, the academic partners, makers of Carbesil, Ilimag, and Injection I3, for being our academic partners for the past 3 months and bringing a lot of important take-home messages to the audience throughout the length and breadth of this country. Thank you again for logging in. We hope to see you soon at the next event. Until then, goodbye, God bless, and take care. Thank you very much.
Thank you, sir.
You can take us off.